Well, welcome everyone to this, our third lecture in the lecture series, joint lecture series between Rural WONCA and Towards Unity for Health. To the topic for the night and play our video, which is on rural workforce retention strategies. And I don't think he needs any introduction, but this is by Roger Strasser, who was the founding chair of Rural WONCA, gave our opening speech at the conference, and is now, and will now see his video, and then two case studies before we go to discussion. So I'll just share.
Hello, everybody. My name is Roger Strasser, and I'm very pleased today to bring you a brief presentation about rural health workforce retention. My background is as a rural general practitioner or family physician in Australia. And in 2002, I moved to Canada to become the first Dean and CEO of the Northern Ontario School of Medicine. I actually left that position in June of 2019. I was also the first Professor of Rural Health in Australia and the first chair of Rural WONCA, that's the World Organization of Family Doctors Working Party on Rural Practice. So today I'm going to briefly set the scene, describing the rural health workforce context, then introduce you to the rural remote workforce stability framework and the three tasks of plan, recruit and retain, and then finally identify the key contributors to successful rural workforce retention. It's quite remarkable that when you look around the world, even though there are obvious differences between countries in terms of geography and climate and so on, the major issues in rural health are the same. Access is the rural health issue. Even in countries where most of the people live in rural areas, the resources are concentrated in the cities. There are always transport and communication difficulties between one rural community and another, and between the rural and the urban centres, and there are never enough providers of healthcare in the rural communities. Looking at rural practitioners, they may be described as extended generalist. When compared to their counterparts in the big cities, rural practitioners provide a wide range of services and carry a high level of clinical responsibility in relative professional isolation. And this is true whether we're talking about in medicine, general practitioners or family physicians, or specialists in surgery or internal medicine or pediatrics. It's also true if we're talking about nurses or nurse practitioners or pharmacists or physiotherapists. Frequently, rural practitioners live in the community they serve, and so they have the opportunity to influence the health of the community at a whole of community level. The best example that I know of this was a doctor in an inland town, a small community in rural South Australia, and he was so effective in presenting the message of the connection between red meat and cholesterol and heart disease that the butcher shop started selling fish. It's very clear that taking health service models from the city and trying to somehow modify them and make them work in the rural areas really does not work. In fact, the most successful health service models in remote and rural communities are designed in the communities, for the communities, by the communities. People prefer to be looked after close to home, and you can't assume that patients will actually travel to access services. During my time, almost 20 years, as a rural practitioner in Australia, twice I had patients choose to go blind rather than travel 2 hours to the closest eye specialist. The role of specialists is really one of support, recognising that the nurses, the doctors, the other health workers in the rural communities are the frontline providers of care, and so the role of specialists is as true consultants. There's a lot of talk in the cities about interprofessional collaboration and teamwork, and it does happen, particularly in specialty units like stroke units and intensive care. My observation is that in the rural communities, this happens much more often because the health workers, they're a team, they live in the community they serve, and they work together to respond to the health needs of the community in which they live. Research that I did over 20 years ago now shows that to ensure sustainability of rural health services, it is a bit like a three-legged stool, and you need strength in all three legs. The hospital or health service, the healthcare providers, the nurses, the doctors, the other healthcare providers, and also active community participation. And this is a theme that I'll be coming back to during this presentation. So let's talk about recruitment and retention strategies. I was actually a member of the expert panel that of the World Health Organization that developed policy recommendations launched in 2010 on the recruitment and retention of remote and rural health workers. In fact, just recently, the World Health Organization has been reviewing the evidence and updating or looking to update these policy recommendations. There were 4 categories of recommendations in the World Health Organization document. First of all, education and training. So that's about recruiting students from rural areas and providing, having actually the education institutions outside of the big cities, providing clinical education for undergraduate and postgraduate education in rural settings, and continuing professional development. Regulatory initiatives included legitimizing the broad scope of practice of rural practitioners, and also compulsory service in rural communities. Financial incentives were about targeted funding to support and encourage practicing in rural settings. And personal and professional support included a comfortable place to live, a supportive work environment, as well as professional development and public recognition of the service provided by rural practitioners. In the last 10 years, it's become clear that sustainable health services models are important, as I've already described, including strong and effective health service management and active community engagement. So now I'm going to introduce you to the Remote Rural Workforce Stability Framework. 5 countries in a partnership over 7 years. These were countries around the Arctic Circle, so Sweden, Norway, Scotland, Iceland, and Canada. And you can see that the framework has 3 tasks: plan, recruit, and retain, and 5 conditions for success. Underpinning this framework is a recognition of the importance to take the long view. Frequently in remote and rural communities, there is this sort of continuous rat race, this focus on filling gaps next week and next month. And you have to step back from that sense of dealing with filling the urgent gaps to actually plan ahead, and particularly to address the issue of transient workers. The work that we did with Recruit and Retain, Making It Work, actually was in Nunavut, an Arctic territory of Canada, and we found that over a 2-year period, there were more than 200 doctors came and went in Nunavut on over 800 contracts. And this was hugely undermining of quality and continuity of service. And so that led to changing the contracting model to encourage the same doctors to come back on a regular basis and to provide some sense of continuity and stability. So let's start with plan. The beginning is really to identify the service needs of the community, then to design a service model that addresses those service needs. That provides you with the basis for identifying, recognizing who you need, what skills, and so that then means that you can move forward with recruitment. And recruitment isn't just about finding individuals with the right mix of skills. It's about recognizing that recruiting a health worker to a rural or remote community is often recruiting a whole family. And so information should be provided about everything to do with living and thriving in this community, including education opportunities, work opportunities for the spouse, social and recreational activities as well. And so the community is really critical to this. Active community participation is critical to helping the whole family to feel at home in the community and want to stay in that community. And to have them stay, this is retain, there's more to it as well, especially for the health worker. It is essential really to have a supportive and friendly work environment and to be able to provide high quality care, accessible and responsive specialist support. There should be relevant professional development, both at the local level, team professional development, accessing online updates, and of course, funded travel for continuing professional development, continuing medical education for the physicians. It's important also that this community, this clinical service is actively involved in education, training and research. And in fact, those sort of involvements actually contribute to retention in the communities and of course provide the potential for recruiting future providers, future health workers for that community and that service. Now, to ensure success, there are these key conditions. The first is to recognise that when you've seen one rural community, you've seen one rural community. So they're all different from each other, although there are commonalities. Therefore, it's including the perspective, the input of the community itself in developing and implementing the plans is really critical. And this can only be done with dedicated investment, real resources to help to make it happen. It's not just a matter of reconfiguring an existing inadequate budget. It's important to recognise that success is a continuous work in progress, and there are particular events that happen on a regular basis during the year. So to have an annual cycle of activities, for example, knowing when the next group of graduates emerge from the education institutions provides a focus for recruitment. Success also is about high quality, sustainable services, and that's about research and development, continuous quality improvement, monitoring and evaluation of all of the interventions. Underlying all of what I presented is the concept of social accountability. As you can see, the World Bank defines this in terms of citizen participation, and the World Health Organization describes social accountability of academic institutions as the institution directing all of their activities, education, research, and service to address the priority health concerns of the community or the region that the institution has a mandate to serve. So how does this happen? Well, it's the partnership pentagram. Commonly, policymakers determine policy. Sometimes they seek input from health service managers, maybe also from health professionals, and occasionally also involve academic institutions. But it's really quite uncommon for the community, the fifth partner in the partnership pentagram, to be actively involved in identifying what are the priority health needs of the community, and yet that is essential. So drawing together what we learned in developing the remote rural workforce stability framework, there are these four key elements. Recognizing what we found was that people in remote rural communities actually have more in common with each other across international borders than they have with the people in the big cities of their own country. It is so important to address the issue of transient workers and to actually recruit workers who make a commitment to be there in the remote rural community on a regular basis, and to assure continuity and quality of the service. Education and training is really central to all of this, recruiting local students from remote rural communities and providing them with their education in those settings, preparing to provide service to their own communities or communities like the ones in which they grew up. That really contributes to stability of remote rural services. And once again, active community participation or community engagement. So drawing this together, I have set the scene, introduced you to the context of rural workforce and recruitment. I have described for you the remote rural workforce stability framework and identified the key enablers of success in rural health workforce recruitment and retention. So in conclusion, I would say successful rural health workforce retention requires multiple interconnected interventions that are based on social accountability with active community participation or community engagement. Here are some references that you may like to follow up from my presentation, and I thank you for your attention.
Thanks very much, Roger, for that presentation. And we'll now, and we're going to go to our next case study, which is by Joyce Baladawa from Kenya. And then we'll
Good morning, good afternoon, good evening, wherever you've been listening from. My name is Dr. Joyce Baladawa, and I'm going to talk to you about our community-based education and services program at the College of Health Sciences. We are in Kenya, just to show you where Kenya is. And it's good to acknowledge our predecessors. Those are the people who have made the program to be what it is. You'll be able to read it in details later. And basically, my case presentation is just to tell you about what COBS is, why we do COBS, who does COBS, how is COBS done, where COBS is done, achievements in COBS, challenges, and of course, the possible areas of collaboration. So, community-based education and services, the training healthcare professional program at Moi University, College of Health Sciences, and we take our students to the community. It's a college-wide activity and constitutes 27% of any academic year, all who are actually trained at the college. We train them in theory, clinical, and field activities. The foundations upon which we base the program are interdisciplinary, interprofessional, integrated, intersectoral, collaborative, and multidisciplinary. Why we do COBS is to ensure that our healthcare professionals get proper grounding in being researchers, healthcare providers, as well as service providers. So they insist on engaging in health promotion, disease prevention, curative, rehabilitation, and intervention. And so who does COBS? Well, we do have 8 programs in 4 schools. So in the School of Medicine, we have medicine, medical psychology, medical lab sciences, physical therapists. School of Nursing, we have community health education and BSc Nursing, School of Dentistry, and School of Public Health. And that is generally an idea of the scope of work. We focus on prevention, promotion, curative, rehabilitation, intervention, and based on the PHC elements as guided by WHO. That's just a list of them. Those are the first 8 elements with the names given in full. How is COBS done? Well, basically, it's a 5-year program. And year 1, we introduce students to the theory. Number 2, they go to the community. Number 3, they develop research proposals. Year 4, they actually implement that proposal. And year 5, they actually go to the county hospital facilities to learn how administration and management. And of course, throughout, it runs the implementation of intervention in the communities. Where is COBS done? For COBS 2, we take them to about 20 stations. To COBS 5, we also take them to another 20 or so stations. That's the list of the facilities where we take our students. And as far as we're concerned, the level 2 is level 3 facilities. COBS 5 is level 5 facilities where they go to learn administration. What are our achievements? From a single faculty of medicine, it's now a College of Health Sciences with 4 schools. From 1 program, we now have 8 programs. We have mentored a number of institutions in COBS activities, and as are listed, there's Maseno, Masinda Mliro, Mbarara, Makerere, Mbale, Mozambique, Rwanda, Uganda. We have made presentations at international forums on COBS-related activities, and the countries we've been to are Ethiopia, Sudan, Ghana, South Africa, Australia, Thailand, Brazil, UK, and had it not been for COVID, would have been in Mexico this year with the Towards Unity for Health program. And of course, we are proud to say that our products are sought after, especially in research areas and in the administrative issues. The challenges, those are the listed: financial, technological advancement, visibility. We try to see how we follow up intervention projects, feedback, stakeholders, and also try to look at collaborations and possible research, focusing on undertaking responsible research. Those are the sites where COPS operates, and those are the exact places where we actually take our students. Those are the drop points where you can actually see students being placed in. Thank you very much for listening. This is from Kenya, Joyce Balidawa, Moi University, College of Health Sciences. Thank you.
Thanks very much, Joyce. That was excellent. And we'll just bring up now the final video from Shantula Chabra from India.
Everybody, I'm Chabra from Mahatma Gandhi Institute of Medical Sciences, Sevagram, and I'm going to share experiences of retention of rural health force at this institution. And actually, this institution is India's first rural medical institute, which was started to meet the needs of rural masses. We are community-oriented and actually partly community-based also, medical education. And healthcare is with the concept of social accountability. And this institution has grown from two-bedded dispensary, which was started by none other than Mahatma Gandhi, way back in 1938. And now it has grown to 982-bedded hospital with retained staff. Quite a lot of people are still there since years. Friends, population is growing and rural too. But rural people have to rely on camps and other things, and this is the crowds in the hospital in rural areas after the camps. And you can see this is the ashram, Gandhiji's ashram, where it was started, and then this gradually over the years there has been development, and now extreme left you can see our maternal child building and the institution grown into an institution with super specialties also. For rural healthcare, what our vision was that students should be from rural background, so we kept quota for rural students. Health professional school was in the village, the nursing school, the nursing college and the medical college in the village itself. And curricula has been rural health inclusive, rural health oriented education on regular basis goes on, and we have rural health assignments for the students. Clinical rotation is in rural health facilities created around the institution. You can see the history, as I said, 1938, the two-bedded dispensary, and now we have nearly 1,000-bedded hospital. I won't go into the details, time doesn't permit. The institution was started way back in 1969. The seat is sown pre-admission. There used to be a paper on Gandhian thoughts, and it was not only the passing but merit was also calculated. Very unfortunately, with NEET coming for medical admissions, this has on. So we feel really sorry, because for one student, the family used to learn about Gandhian philosophy. But we have orientation camp for 15 days in the hostels when the students come. They live in Gandhiji's ashram and learn to live with simplicity on Gandhian's ideology. Fortunately, we have been able to continue this. And social service camp is at the end of first semester, pre-first vacation. Each batch is put in the village. They live in the village. The faculty, the postgraduates, the interns and others go with the students. They also, some of them live there, some go and visit and come back. And the students adopt families which are with them till they pass until their internship. So they really learn the rural real life and the problems of the health problems, the social problems. Reorientation of medical education was started way back by Government of India in 1977, but the fate, I have put a big query, I don't know. I think it's not going on in India. But we continue. Final MBA students go to a village. Again, they live in a village where we have our own health center. They are given a project which is rural, looking at the rural needs, the social aspects of health, and they learn about the problem, the solutions. And as they pass during internship, they are posted in rural centers for 6 months. Then there is a question of how to provide doctors for rural areas. So we, way back in 1992, we started this, that we nearly 100 non-government organizations who were working in the rural areas, extreme rural areas. We were used to, the posting was as per the merit, the students were given choice out of these places, and it was not paper posting. But the students have to, the new pass out students have to go to the villages and centers and work there. And even the dean goes and sometimes checks and used to get feedback. Very unfortunately, this has gone as per UG, for PGs also, we are trying. Hopefully, we will get 50% at least for this. Other rural retention incentives were for retaining people. What we did was financial incentives, personal support, professional support, continuous professional development for rural health workforce continues in this institution. And the actions which really facilitated was housing for and other activities, be it cinema, be it doing things for themselves. As you can see, we call it Shramdan. You take care of your own water, you ensure that the roads are there. You can see at extreme left a director participating in Shramdan activity, and this used to be our area. And the extreme right is the place where our director lived. We used to clean our own campus. The activity still goes on, but it is a little less than what it used to be. New housing has come as things have changed from 1969, and people have better places to live in the same village. As everything is growing in the world, this place also. Then we ensure that the children get education, so kindergarten to school, and jobs for their spouses in the schools. And then this was also ensured that for children there is some system at least for higher education. Some people will like to go somewhere to do other things, but for nursing school and medical school seats we can put up. And that also the medical seats quota has gone with NEET. But yes, nursing still continues. In nursing school, we are nursing college up to PhD, from GNM, General Nursing, Midwifery Diploma, to PhD also we have. Other faculty incentives were personal promotion schemes, study leave for personal reasons. Maybe financial gain, people have gone to Saudi countries and they found money and come back. So they were allowed that also, for they want to go for a year or two. And deputation is also permitted, for on-duty deputation for learning and academic development. Other activities were also, and partly this has gone with information technology developing and people having many things on mobile. We used to have faculty sports, staff club, even movie in theatres. Some of these activities continue annually, but those monthly activities have almost gone. Now, as we developed in Sevagram, now it's much developed. We have super specialty, neurology, cardiology, and gastroenterology, and others also. We realized that there is a place called Melghat, just 5 years distance from here, where it's a remote rural region with access problems, extreme poverty, high maternal mortality, child mortality, and nutrition problems. To get persons there is difficult. Was difficult 8 years back when we thought about this. Now also is difficult. So when you don't get, there's no question of retention. So what we did was, and we are continuing with that, is deputation for rural posting, specialist residents and interns. We have CME. Their helpers also join. So in true sense, it becomes interprofessional learning and relearning of everyone. You can see now we have developed there a 50-bedded reasonably equipped hospital, and from there we have adopted some 140 villages where our doctors go, our nurses go. Actually, we are tracking each pregnancy in these 140 villages. We conduct camp annually. Now, last year, we could not do in Feb and September. We don't know. Maybe after 6 months things will settle and we'll restart. And in these places, we are getting nurses, technicians, and other persons, but doctors is still difficult. So we are deputing our own team, which is provided accommodation in the hospital building itself, water, electricity, meals, television, mobiles were started, but we are not giving. It was very difficult to maintain. You can see the accommodation and the campus there, and they are helped to have sports, cricket, badminton, football, carom, and other things. And this is what Gandhi said, that the journey of miles begins with first step, and our first step was Gandhi's own dispensary, which has grown. We have not been able to do, I should say, a lot, but yes, we have done something and we always feel proud of it, that we have done something for the rural masses. Thank you, friends.
So thanks very much to Roger, Joyce and Shakatullah for those presentations. Roger.
Well, thank you very much, Bruce, and welcome everyone to this session on retention of the rural health workforce. We've seen 3 short videos to set the scene and to generate discussion, and now this is the interactive part of this session. It seems to me that this session has followed very nicely from the first one in the series that was about the rural training pathway that Bruce presented, and then last week colleagues from South Africa about learning to practice in the rural setting, at least the advantages of education in the rural setting. And so today our focus is on retention, well, recruitment and retention, but of course the key is keeping the rural practitioners that we have in rural communities. We've seen from my presentation, which gave an overview, but particularly drew on work around the Arctic Circle in Northern Europe and North America. Then presentations, great stories of success from Africa and then from India. So as in the previous sessions, you have the opportunity to ask questions and make comments. And I encourage you to do that through the chat function. We have several chat comments and so we can pick up on those to start off with. And then if anyone has a specific question, comment, point that you would like to make, then please signal and take yourself off mute, and then we'll discuss that. So just looking quickly at the chat comments that have come in, we had Rick Botello asked about a follow-up from the 2010 World Health Organization policy guidelines. During this past year, there's been a full review of the literature, and then a meeting of the Policy Guidelines Development Group, and a new report, a 10-year review and update of the policy is about to be formally launched. It's completed, just is about to be published. The next question from Billy O'Connell, I think behind that comment is the notion that the longitudinal integrated clerkship and the value of that in terms of the student learning, and that this commonly, of course, is based in general practice or family medicine. And I think, Billy, and maybe you can speak to this, but what you're suggesting is that there's value in students having longitudinal experiences in other specialties than general practice. Of course, I would say there's truth to that, and there are models of longitudinal integrated clerkships in different countries with students across a whole range of specialties. The advantage of general practice, particularly rural general practice and longitudinal learning, is that the students see a wide range of clinical problems. They have lots of hands-on experience, so it's high quality hands-on learning for the students. In fact, the rural setting, as we heard last week, is a great place to learn clinical medicine, and so that needs to be recognised. I'd also point out that there is something of what Bruce calls a dose response. That is, the more time students spend learning in rural settings, the more likely they are to choose to practice as rural practitioners after they complete their education and training. The next question, it's a comment really from colleague from Uganda, Kansi, about about COBIS, and of course we heard from Kenya and the Moi University and the experience there, but as it says, all the Ugandan schools have COBIS as well, and in fact it was Ilorin University in the 1980s that initiated this community-based education service. So do we have any other? A lot more comments. Okay, maybe we'll just stop there and see if any of the individuals who've made those comments want to add to that, and then gives me a chance to read the the other chat comments and then make any responses to those. Let me say that the question about sharing the presentations, the entire session is being recorded and will be available for everybody to access after today. And so you'll be able to review the videos and also this discussion part as well, and have access there therefore to the slide presentations. Comments, discussion, let's see. So, El Hadi Miskin talking about community-based education, University of Bisha. Did you want to say anything about that, El Hadi?
Okay.
Go ahead.
Okay. Thank you very much. I am Hadi Miskin, graduated from University of Jazeera and start my professional career there in Sudan. The university, which is known among the first medical schools, started community-based education in Africa, really. I recently shifted to Saudi Arabia. I noticed that the medical school of Bisha in Saudi Arabia is located around a very rich rural area with the main stakeholder student came from surrounding more than 250 villages around the city, around the small town, Bisha, where the university is located. We start to update our curriculum by community-based medical education modules in order to be, because we think that this is a suitable curriculum to be adopted in such situations. Fortunately, now this project are running with the FEMER Institute, Asio Fraimina, submitted for the fellowship, FEMER fellowship, and now I am working on it properly. We are in the implementing phase. We already we raised the awareness regarding the community-based education among the faculties, among the students, the stakeholders, community leaders. We run a lot of workshops in this regard, and now we are with working together with a small technical committee from faculty. They have experience in community-based education in curriculum update, and I think most probably it will be presented in TAF 2021, inshallah. At the end, thank you very much for the amazing session and amazing presentations and case reward. And I am so happy to be with you this day. Thank you very much.
Well, thank you. And it's very exciting to hear that the experiences in Africa and Jazeera now being transferred to Saudi Arabia. And I think it highlights, as I described in my recorded presentation, that how much we have in common. Rural communities have so much in common with each other, from one rural community to the next, and even across international borders, and in many ways more in common with each other across those borders than we have with the people in the cities, the big cities of our own countries. I see there was a question from Tapesh Dutt Nagaria asking about rural workforce retention experiences in countries which have universal healthcare and those that do not. I'm not sure, even with the examples that we presented, whether you would consider Kenya and India as having universal healthcare, and yet these are examples of successful models that are producing and retaining rural practitioners. Do you want to enlarge on your question, Tapesh?
Yes, hi. So good afternoon. It's really nice to see all of you again after, I guess, 1 full year. I saw all of you last during the World Rural Health Conference, in New Mexico, and it's really nice. I missed Bangladesh this year. So yeah, my question was because in our institution, we're doing a research about possible avenues for expansion of universal healthcare systems in India. Now we have a partial universal healthcare system in India called Ayushman Bharat, which first of all aims for the poorest of the poor, so to the most vulnerable of the people. Now, one of the biggest issues we have in India is that, Shakuntala, Dr. Shakuntala ma'am pointed out that I also actually come from the same area as ma'am. My hospital is actually 10 kilometers away from Dr. Shakuntala ma'am's hospital. And the issue that we often see is that in rural areas, patients are not that much well-to-do as they are in the urban areas, because there is an obvious income divide between urban and rural areas. So that means that universal healthcare systems have to be even more robust in rural healthcare in rural areas than in the urban ones, and because retention is a very big factor in implementing rural in universal healthcare and in especially in rural areas. I was just hoping to see that does a country which has universal healthcare, where doctors are they have a sort of salary from the state, where they have sort of permanent employment and other benefits of a government employment, does that change experiences of if someone has universal healthcare or if someone doesn't? I know that my question got a bit twisted, so if it's not, I'll just repeat it again, but I'm sorry that I was a bit confused. I lost track of my thoughts.
Yes, well, thank you very much. I think you've raised a really important question. And I guess my short answer would be there isn't necessarily a connection between universal health coverage or universal health care and success in terms of retention of rural practitioners. Effective universal health care, certainly, or health coverage, certainly is likely to be a facilitator, but it isn't the whole story. So, for example, we have colleagues with us from Colombia, and I'm working with Norwegian colleagues, the Norwegian Center for Rural Medicine in Colombia, with working on rural health for peace in a rural part of Colombia. And Colombia on paper has 96% coverage of the population for health insurance, and it's through what are called health maintenance organizations. But when you get to the rural and particularly the remote rural communities, there is still the essential issue of access or lack of access to health care. There may be a doctor in a community that's 1 or 2 hours away if the roads are good and you have transportation and so on. So on paper, Colombia has universal health coverage, but in practice for people in rural communities, access is still the issue. And so that what we're finding in Colombia is the value, the importance, the essential requirement that local people in the community stand up and take responsibility. And so it's that active community participation, the community engagement that I spoke about. And already we're seeing, after a couple of years, some new thinking and change in approach in these communities, because what it really requires is for these communities to stand up and to hold, shall we say, the health system accountable with the notion of social accountability that the World Bank uses about a civic engagement. And so that's what we're seeing happening in Colombia, and that's combined with the World Health Organization of social accountability concept in terms of education and training. So academic institutions committing all of their activities, education, research, and service, to address the priority health concerns of the rural communities. So these are happening and need to keep happening, in a sense, whether you have officially universal health coverage or not.
Okay. I have two follow-up points, if that's okay, if I can ask.
Go ahead.
One is directly related to your answer and the other one is not. So the one that is related to your answer is that I worked in Denmark for about a year before, as part of my internship at my hospital. Now there I was in a rural area and in an urban area. Now from my experience there, what I saw was that doctors didn't really care whether they were placed in a rural area or an urban area, especially young doctors such as myself who were just starting out in their career, because for them, the benefits of both of them were sort of similar. Right now, what my generation, I would say, I won't make any generalizations, but right now, what my generation sees, at least in India, is that if you move to an urban area, we can move to private practice because private practices are more available sort of in private practices and hospitals are more available in urban areas. So they have more monetary incentives to go there. And that also brings, so I was asking that, is that experience that, young doctors don't feel much of a difference when there is universal healthcare, whether they are in a rural or an urban area, is valid or not? And the second point, which brings me from the monetary aspect, is that right now in India, we have sort of a carrot and stick approach to keeping doctors in rural areas. So for example, people who are educated in public institutions, they have a bond or a service duty to do service in rural areas for 1 year, 2 year, 3 year, depends on which state. And the other one is there is a carrot in the form of monetary incentives and other incentives such as preference in residence seats and of those sorts. My question was that is this carrot and stick approach that, incentives or punishment sort of thing, is that a sustainable model for keeping workforce retention in rural areas? Because it seems like it will last until they have money and then the system will break down. I know that I'm not an expert in this field. I am just speaking from my very, very limited experience as a very, very young doctor, because I graduated last year. So I have literally just 14 months of experience. So that is my question.
Well, thank you. Excellent questions. Let me take the first one first and actually defer the answer to next week. So next week's session is actually the young doctors presenting. So come back next week and hear from Amber Wheatley, Mayara Floss, Veronica Rasic and others on rural seeds, and they can talk about the experience of young doctors around the world. The second question about the mixture of carrots and sticks and financial incentives and rewards, I think you're behind your question is a sense of doubt that that's enough to maintain retention, and you're right. I think the evidence is clear, and certainly, as I mentioned, this was reviewed by the World Health Organization 10 years ago, and then this year. Those sort of interventions have some effect, but it's a short-term effect, and that's why it's important to implement all of those tasks: the plan, recruit, and retain. And each of the elements in that with the success conditions to be sure of ongoing success, and underpinning all of that is active community participation. So I think that's a quick answer to your question. I noticed some other comments on the chat, and we've got about 5 minutes before we finish. So Can
I say something, Raghu? Can I say something, Raghu?
Sure, Shabra, go ahead.
I actually wanted to share that since now we are working in further remote area, one keeping persons having, Dr. Tapesh said something about government people. Sometimes they are posted there, but we have to ensure that the knowledge, the skill needed is essentially with them with infrastructure. So just keeping persons doesn't help. That's 8 years now we are working in remote. I'm officer on special duty for that remotest hospital where we are open. And the other is that you have to take community all the time with you. Because what we have, I'm working on the deaths from 2012 to 20. I analyzing everything, and it's having doctor, the knowledge, the skill, the infrastructure, and the beliefs of the patient communities. If they are not happy with your health facilities or they are not interested, then it is very difficult. You have the team, but you remain where you are. So it is actually a comprehensive thing one has to think when you're talking of these people, and community has to be always in the picture. Talk to them, believe them, and keep them with you. And it's not that you tell them this is to be done. Ask them what is needed, and accordingly you modify and reach them. And as I'm trying to track each malnourished baby and each pregnancy, we learn and we ask them what is available, what is your difficulty, and then we try to modify our own way of care. So these are important things when you are talking of rural health, which should always be remembered. Thank you.
Right, thanks, Shabra. So I was going to ask you to make some comments and you beat me to it. Just a couple more comments based on the chat, and then I'll ask Joyce if she has any final comments to make as well. But I think Shabra's point is important. There's a specific range of knowledge and skills that are required for success as a rural practitioner. So the education, training and professional development needs to support that. And it's a continuous work in progress, active community participation on an ongoing basis. There have been some questions about social accountability. And let me just say, first of all, there is a global network of schools that have that are guided by social accountability. This is the Training for Health Equity Network. We heard from Gezira earlier, or about Gezira. That's one of the members. Northern Ontario School of Medicine in Canada is another member. James Cook University in Australia, and there are many others in different countries, South Africa, Walter Sisulu University. So there are good examples in lower and middle income countries, and as well as the developed world, of successful social accountability. Holding government to account is very much something that starts with local community engagement and actual really a strong push from the community that encourages the politicians to recognize that the importance of supporting high quality local healthcare. And so once again, it comes back to active community participation. I remember when we had the Rural WONCA conference in Nigeria back in 2008, we were in a small rural community, and one of the participants in the conference commented that, there seem to be always shortages of rural doctors in these communities, but there are never shortages of rural politicians. So I think the importance of putting the pressure on the politicians is a way of getting to government. I see the comment about Taiwan. In fact, there's good evidence of the success in Taiwan of recruiting and retaining rural practitioners, as was mentioned. Now, Joyce, any comments from you to follow up the discussion and your presentation from the beginning? Joyce.
Yes, thank you very much and for allowing us to have this opportunity. My comment is basically to say that our training has actually made what you would call well sought after products. And we feel that it actually, if given the right support, we should be able to encourage a lot of people. So what we have in Kenya basically is that when most of these students finish, they are given a period of time to work at the county level facilities where they're actually in the leadership role. So they're able to continue with whatever it is that they have learned from the institution, and they actually participate in the community. So when the students actually go there again and they feel, their own are the ones in charge of those facilities, it makes it, a kind of incentive. There's an earlier research which we did, and we asked what would keep doctors in the communities. And they told us that make sure you're giving us enough money, make sure that you are making sure that our social amenities are taken care of, And they also made sure that generally what we are living, how we live in town, we're able to live in these communities. So if we make sure that we're taking care of those, retaining our healthcare professionals in the communities would not be too much of a challenge. And of course, we have to make the work environment exciting, challenging, and of course, income generating, the way doctors would like to earn all those little perks they get here and there when it comes to clinical practice. Thank you.
Well, Joyce, I think they were wonderful final words and really a strong take-home message to all of us as we come to the end of this session.
Roger, can I say something? I see a question about social accountability, government doing lip service. What our experience is that these things, those who work at the periphery, they have brilliant ideas, and most, if you put it in the right way, the government, like, it won't come from up down. You have to, from the lower part, it goes to the government with clear cut that this is the problem and this is how you have accountability to the people. And then things move rather than expecting that the government on their own will start. Thank you.
Yeah, thank you, Shabra. So once again, the point that I made, that it's starting at the local community level of building advocacy and putting pressure on the politicians, on the government to act. That's social accountability. We have come to the end of the allocated hour for today's session. It's been very full, and I'd like, on behalf of everybody, to thank the two case presenters, Shakuntala Chabra and Joyce Balandawa, so from India and from Kenya. Bruce Chater has been moderator, is now off saving a life, as rural doctors do. And I want to thank you all for your participation. I remind you that next week, same time, we have our next session in this series, and it's the supporting young health professionals in rural settings. So I look forward to seeing you all then. Thank you very much, everyone, and goodbye.